Chapter 21. This is going over the heart and heart anatomy. We are in the cardiovascular system. So chapter 20 was blood. Blood is the transportation system, and the heart is the engine that drives that transportation system. The heart is a muscular pump. Actually, one of my favorite organs. I find the heart really fascinating and always really interesting to study physiologically, because the heart has really one purpose, and that is to contract and pump blood continuously. It cannot stop. We need our blood to travel long distances in our body, of which diffusion does not work. Diffusion only works for short distances. And so we use the cardiovascular system to transport things long distances throughout our body. And the blood is how things get transported, but the heart is really the pump that drives that transportation. And it has to stay in motion because we need oxygen delivered at all times to the cells of our body, and we need carbon dioxide taken away so we don't get too acidic. We need nutrients delivered to the cells, and we need our waste products taken away. So the volume of blood pumped by the heart, and this is a volume, an actual volume of liquid blood being pumped or circulated through our cardiovascular system or circulatory system. And we actually measure it in liters per minute. Now, this is actually what we call our cardiac output. So our cardiac output is equal to the volume of blood pumped per minute. And this is a really important measurement. The cardiac output, your cardiac output at rest is around 5 liters per minute for everyone. Everyone has a basic need of around 5 liters per minute at rest. And that's important to understand. This is your basic circulatory needs. You need to have 5 liters of blood circulating per minute, being driven by the heart in order just to meet your basic physio needs. And if your heart starts to deliver less than 5 liters per minute at rest, then we would start to term someone as having heart failure or circulatory issues. And we'll get into that a little bit later and definitely more when we talk about physio. Okay, but why would you go from 5 liters to 30 liters? What's going on when you're upwards of 30 liters per minute? Any ideas on that? Well, you get greater than 5 liters per minute of cardiac output when exercising, right? When exercising, or you need increased circulatory demands. So when you're exercising, you need more oxygen being delivered, and you need more nutrients being delivered, and you need more carbon dioxide and waste being taken away. And so when you have an increase in demand, you have to meet that demand by having more blood circulating faster. It's kind of like Amazon Prime these days. There's always an Amazon Prime truck going down the street because we have an increased demand for people having things delivered to their homes. And so now we go from having 5 trucks on the road to probably 30 trucks on the road. So our cardiac output's kind of like that. It has to increase to meet the demands. All right, so heartbeat, yes, beats a lot of times per day. This is assuming you have a normal average heartbeat of around 70 to 90 beats per minute. And the heart is controlled by the autonomic nervous system. Okay, so anatomy of the heart. So the heart is a muscular pump, and it's what we call a double pump. But really I say triple pump, and I'll say why. I mean, I include the coronary circuit because that's super important. But here it is. You have the heart, and you know what kind of artist I am, so I'm going to make it really artistic. All right, so here's your heart, and you have 4 muscular chambers. And so you have a right atria and a left atria and a right ventricle and a left ventricle. And the heart is one muscle, right? So it's one muscle, or acts as one muscle, right? So acts as one solid muscle. And so as the heart contracts, it's pumping blood from the right side of the heart to the lungs. And that's called the pulmonary circuit. And at the exact same time, the left ventricle is pumping blood elsewhere. And this is the systemic circuit. So these are both happening at the same time. So again, you have 2 pumps. You have, oops, I'm going to make that a 2, and I'm going to make this a 1. So you have blood going the pulmonary circuit, right? That's from right side heart to lungs and back to left side heart. And then you have the systemic circuit, which is from left side of the heart to cells body all over, and then back to right side of the heart. So you have the systemic circuit and the pulmonary circuit. It's happening at the exact same time. It's one contraction, right? So this is contract and that's contract. And so the heart's contracting at the same time, but it's pumping 2 different places. And so the right and left side are really independent of one another in a certain sense, right? The right side of the heart's pumping blood to the lungs and then back to the heart. And the left side at the exact same time is pumping blood to all the cells in the body and then back to the heart. So that's a systemic circuit. Well, there's this 3rd circuit called the coronary circuit. And the coronary circuit sends O2-rich blood from basically the left side of the heart, or left ventricle, to the heart muscle itself, and then back to right side of the heart. So the coronary circuit is delivering blood to the heart muscle itself, right? And so another way to say is delivering blood to the heart muscle itself, because the heart muscle needs to have an infrastructure too. This just go over, again, cardiac output, right? And we talked about cardiac output. You need to start wrapping your head around cardiac output. Okay, so this describes the pulmonary circuit and the systemic circuit. And so you can go through the definitions. Pulmonary circuit is oxygen deficient blood from the heart back to the lungs, or to the lungs and then back to the heart. It's a relatively short distance circuit, right? So if we're looking at this, this is the right side, and here's going to the lungs, and here's going to the other lungs. And then it's coming back, right? And comes back. So this right here is the pulmonary circuit. The lungs are right next to the heart, right? So it's a short, low pressure system. But when it comes to the systemic circuit, right, coming from the left side, it's got to go up and service this whole area, and it has to go down, right, and service everything down here and make it back to the heart. And so it's going to be a high pressure system in arteries. Veins become a low pressure system, but there is going to be a lot of pressure. The pressure is going to be the highest here, right next to the heart in the aorta. The third system is the the coronary circuit, and it's delivering O2 rich blood to the myocardium or heart muscle and returns it back to the right atrium. Now, important to understand, equal volumes of blood are being pumped at the exact same time. So whether it's half the blood's going to the pulmonary circuit to get newly oxygenated, because the right side is taking blood that's coming back from all the cells in the body. The oxygen has already been extracted from, at least 25% of the oxygen has been extracted out of the blood. And so it goes to the right side to get sent to the lungs to get that oxygen fully saturated again, put it back up to 100%. And that's the pulmonary circuit. And then from the left side, so that newly oxygenated blood is delivered to the left side of the heart, and then the left is pumping out that newly oxygenated blood to the systemic system, right, to all the cells of the body. And these are equal volumes of blood being pumped. Now, anatomically speaking, when we look at the right ventricle versus left ventricle, the right ventricle is going to have a much, much thinner myocardial wall because it doesn't need to pump with that much force to get the blood over to the lungs next door. But the left side of the heart, which has to pump the blood to the systemic circuit, it's got a long way to travel to get the blood down to your toes and back up, or your head and back down. And so that muscular wall is going to be a little thicker because it has to create a lot more pressure. All right, so make sure you understand pulmonary circuit and the anatomy of the pulmonary circuit and the systemic circuit, and as well as the coronary circuit. So don't forget about the coronary circuit as well. All right, a few more definitions. I want to get this kind of taken care of right now. Artery. The definition is a vessel that transports blood away from the heart. So that's an artery. As opposed to a vein is a vessel that transport blood to the heart. So if a vessel is going towards the heart, then it's a vein. If it's a vessel that is going away from the heart, then it is an artery. Remember, it's not a colored thing. And I say this because when you're looking over here, this right here is an artery, right? It's the pulmonary trunk. And so this is an artery, and it's blue. And these right here are pulmonary arteries. The pulmonary veins are red because, remember, in the pulmonary circuit, definition of an artery is transporting blood away from the heart. Well, this is transporting blood away from the heart to the lungs, but it's going to the lungs to get oxygen, right? And so it's got a bluish hue to it because it has less oxygen. As it's going in the lungs, it gets oxygenated. And then the pulmonary veins are 100% oxygenated, so it looks reddish. So veins and arteries are not necessarily a blue and a red thing. It's is that vessel delivering blood to the heart, or is it taking blood away from the heart? If it's taking blood away from the heart, it's an artery. If it's bringing blood to the heart, it's a vein. And then where things are exchanged in the periphery, we call these capillaries, right? So capillaries is where things can leave circulatory system. So Circulatory system is a closed system. So this is a closed system, meaning vessels originate from the heart, they become smaller and smaller until they're capillaries, and then they merge and become bigger, bigger, bigger until they become veins, right? So vein, artery. These vessels begin at the heart and end at the heart. It's a closed circuit. And the only place where things leave this closed circuit are the capillaries, right? So the capillaries are what we call the exchange vessels. All right, so pulmonary blood flow, and this goes through. This right here is the superior vena cava, and this is the inferior vena cava. Superior vena cava is bringing blood back to heart if, so I shouldn't say if, brings, let me put it a different way. Superior vena cava delivering blood back to heart from everywhere above diaphragm for the most part. Okay, so everywhere above diaphragm, all these vessels are going to merge into the superior vena cava, and the inferior vena cava vessels merge. So inferior vena cava is delivering blood back to heart from all areas below diaphragm. So inferior and superior vena cava, biggest veins, delivering blood back to the right atrium. So this is the right atrium here. Some other anatomy on the right side, this is pulmonary. So AV valves. So this is the right AV valve. That's one cusp, there's another one, and there's a third one. That's why it's a tricuspid valve. But you could say right AV valve, A is for atria, and V is for ventricle. Atria is just the plural form of atrium. So if it makes you more comfortable, we could say atrium. So the right AV valve is where blood coming from the superior and inferior vena cava. And by the way, this right here is the opening of the coronary sinus, and we'll talk about this a little bit later, but that right there is the opening of the coronary sinus. And the fossa ovale is where there was a hole before birth between atria. Okay, so the fossa ovalis is where there was a hole. It's now just a fossil. It's sealed up, but there was a hole between the atriums because before you're born, you're in amniotic fluid. You don't have gills, so you can't breathe in fluid, and so you're getting your oxygen from your mother, right? So the umbilical cord is delivering oxygen-rich blood to you in the placenta, and so your mom is breathing for you. You don't actually use your pulmonary circuit separate from your systemic circuit until you are delivered. And that is why they used to listen for the baby's cries, because if you can make a sound, that means oxygen is moving over your vocal folds into your lungs. And so sound indicates that there's airflow. So this hole has to close up between the right and left side, because once you're born, you really need to separate your deoxygenated blood that needs to go to the lungs and get new oxygen from the left side that is supposedly oxygenated, fully oxygenated blood that's going out to all the cells in the body. So when babies, they can now see this on ultrasound. If the fossa ovalis has not closed up, they will go in and close that hole before the baby's born, so the baby can breathe and deliver oxygen properly. Okay, so the right AV valves, there are these little cords called chordae tendineae that hold the valves to these muscles in the wall called papillary muscles. Okay, and these papillary muscles are right here. There's one there, and these muscles will hold the valves shut when the heart muscle's contracting. So this right here is the right ventricle. And then the right ventricle will funnel the blood to what is the pulmonary, and we like to say semilunar valve. So this is the pulmonary semilunar valve. When the heart contracts, it will force this valve to open and blood will go up in the pulmonary trunk. Now this is an artery. And then the pulmonary trunk, it's like a tree trunk, it's going to have branches. And so these are the branches of the left pulmonary arteries, and these are the branches of the right pulmonary arteries. And then it will go to the lungs, and then return pulmonary veins back to the left atrium. But at this point now, it's oxygenated blood. So let's do this. Okay, so that's the pulmonary circuit. Now, again, pulmonary circuit is to have the blood as it passes by, get new oxygen and get rid of the carbon dioxide. And so the blood returning back to the left side is going to be newly oxygenated blood or oxygen-rich blood. Now, the systemic blood flow is where you have newly oxygenated blood returning via the pulmonary veins, right? So pulmonary veins to the left atrium. You have a left AV valve. Excuse me. It's also called the mitral valve or the bicuspid. Oh, whoops, I didn't spell it right. Let's do that again. Because there's two flaps, two cusps. They're chordae tendineae, again, attached to papillary muscles in the myocardium. Now, this is all left ventricle. You can see how thick this muscular wall is on the left, right? So left ventricle versus right, very, very thin. Again, the right is a low pressure system. The left is a high pressure in arteries. Okay, as this contracts, it's going to funnel blood up here. What you're not seeing is a semilunar valve here. So you have the aortic semilunar valve. And then it's going to send blood up the ascending aorta, aortic arch, and then descending aorta. There are three main branches off the aortic arch that are going to service the upper body, and the first one's the Brachiocephalic Trunk. Anytime you see the word trunk in the circulatory system, you have to understand there will be branches, like a trunk of a tree. You're going to have branches off that trunk. And so brachio is going to stand for going down the arm, and so that is the subclavian. And then the other branch is going up, and that is going to be the right common carotid that goes to the cephalic part, right? So that is the cephalic, and subclavian is the brachio. And then you just have the left common carotid and the left subclavian. So brachiocephalic splits into the right subclavian and right common carotid. Then you have left common carotid and left subclavian. Then the aorta descends, goes down, and you have branches off that to the other systems. Eventually, all those branches merge, and it's going to bring blood back from below the diaphragm to the inferior vena cava, or from above the diaphragm to the superior vena cava back to the right. So the heart is slightly to the left, and because of that, it kind of makes the left lung a little bit thinner. This is the left lung, slightly to the right, slightly to the left. And this kind of shows you below the thyroid. It's not showing the thymus there, but a few other things I want to point out. This is the aorta here. So let's do this is aorta. And again, you have the left subclavian, left common carotid, brachiocephalic trunk, right common carotid, right subclavian. So that's the way these are going. The superior vena cava is returning, and you have two subclavian veins that then merge to become the superior vena cava. So you have two brachiocephalic veins, and we'll go over this when we get to circulatory, but I wanted to show you this. Now why I put valves, veins. So two brachiocephalic veins. You have one brachiocephalic artery, two brachiocephalic veins. As far as the anatomy of the heart wall, hopefully you guys remember, there is the serous membranes. And so you have the parietal pericardial membrane, then you have the pericardial cavity or space, which is between these two membranes. And then you have the visceral pericardium. We also call the visceral layer of the pericardium the epicardium. The epicardium is the visceral layer of the pericardium. Then you have the myocardium. And then lining the inside of the chambers. So lining inside of the four chambers. And again, there are two atria and two ventricles, is endocardium. Endo meaning inside. And that endocardium also makes up the valves, right? So you have two AV valves and two semilunar valves. So there's three layers of the heart muscle wall, right? You have one being the epicardium, then the myocardium, then the endocardium. And on the way, after the pericardial cavity, you have the parietal pericardium way on the outside. And it's connected to something called the fibrous pericardium. Again, myocardium are these interlocked branched muscle fibers. There's actin and myosin and sarcomeres, but they have these gap junctions that allow for the electrical impulse to flow from one muscle cell to the next. So the whole heart acts as one giant muscle or muscle fiber or muscle cell. So again, you got the outer epicardium, then you got the myocardium, and then you have the endocardium, which includes, again, the valves. So pericardium and myocardium in the middle, parietal pericardium on the outside, and parietal pericardium is connected to what is called the fibrous pericardium. It's a fibrous sac, and it actually anchors the pericardial cavity to the diaphragm. So this pericardial cavity, this parietal pericardium, the pericardial cavity or space, and the epicardium or visceral pericardium, it surrounds the heart, and then it's actually attached to the diaphragm. So it really keeps the heart in one place and helps distribute the force of this contraction of the heart. And so this kind of goes through with this fibrous skeleton, which is this right here, what it does, right? And so it stabilizes it. It also kind of reinforces the valves, distributes the force of the contraction, helps the heart return to its original shape, and also, yes, isolates the heart. Again, cardiac muscle cells are branched, and they have what are called intercalated discs. with these gap junctions that allow for ions to move from one muscle cell to the next. So it depolarizes each muscle cell as it goes along. Just flows from one to the next. So it's in sync. It's functionally in sync. Orientation, again, it's slightly to the left and rotated so you see more of the right side anteriorly. So you see more of the right side on the anterior surface and more of the left on the posterior surface. We have the 4 chambers of the heart. You have the right atrium and the right ventricle. Then you have the left atrium and the left ventricle. Again, there are things that separate it. So you have what's called a coronary sulcus here between the right atrium and ventricle and between the left atrium and ventricle. And then you have an interventricular sulcus coming down the front. Coronary arteries tend to reside in these sulci. So here, and veins. And so this kind of goes through the coronary sulcus, and then there's an anterior and a posterior interventricular sulcus. Again, you have to know the anatomy. So understanding, brachiocephalic first branch off the aortic arch, left common carotid is the second, left subclavian is the third, then it goes down. So you have the descending aorta, the ascending aorta, and the aortic arch. Pulmonary trunk is an artery, and then it branches to the left and right pulmonary arteries. On the backside, this again is showing you the different chambers. So we have 1, 2, 3, and 4. Again, we see more of the left side posteriorly, but this does show you pulmonary arteries going and branching, and pulmonary veins coming back into the left atrium. This is also showing you the coronary sinus. So all coronary vessels are going to originate here in the aorta. Vessels originate in aortic sinus. So it's in the aorta here. And then you're going to have 2 branches off it. You're going to have a right coronary artery and a left coronary artery. And left coronary artery. And all of those coronary arteries, they're branching, they're servicing all of the heart muscle, and then they all start to return back to the right side. And the coronary sinus is where all coronary veins merge to bring to pour blood to right atria for pulmonary circuit. And so the coronary sinuses are kind of where it all merges, and this will open up into the right atrium to return oxygen poor blood from the coronary circuit back to the right atrium. So going through the anatomy again, on the outside, these are all things that you need to know. And let me emphasize the auricle. The auricle is just this ear-like flap, but it is only part of the atrium, the ear part. So it's the ear part of atrium, but not all of atrium. So you're going to see right and left atrium, and you're going to see the auricle of the right and left atrium. It's just the ear-like flap. So you can see this is left atrium, and still a lot of it that's not part of the auricle, and then this is the right that's not part of the auricle. You're going to see the brachiocephalic trunk, left common carotid, left subclavian, the arch. The ligamentum arteriosum is that ligament that connects the aortic arch to the pulmonary trunk. You have the pulmonary trunk, pulmonary arteries, and you have the interventricular sulcus, coronary sulcus, and yes, the superior vena cava. And what it's not showing you is inferior vena cava. Here on this side, it shows you superior vena cava and inferior vena cava. This is also showing you right pulmonary artery and left pulmonary artery and left and right pulmonary veins. Here is the posterior interventricular sulcus and again the coronary sulcus. The coronary circuit again begins this area right here where the right and left coronary artery originate. This right here is called the aortic sinus, where left coronary artery and right coronary artery originate. So aortic sinus is where the right and left coronary arteries originate. And so that's left coronary artery and that is right coronary artery. Right, it looks like I'm pointing to the vein. Let's do a little bit darker, shall we? This is left coronary artery. And this right here is right coronary artery. So left and right coronary artery, the left coronary artery kind of goes around that way and then down the left ventricle. And the right coronary artery comes down here and then down the right ventricle. So this right coronary artery and left coronary artery. And so all of these arteries eventually become veins. And you have the middle cardiac vein, you have the great cardiac vein, and there's a small cardiac vein here as well. And these veins are going to merge into the coronary sinus, where coronary blood returns to right side of heart. So when it goes through the coronary circuit, it begins at the aortic sinus, coronary arteries, coronary veins, and returns to the coronary sinus. Here on the inside, you can see the opening of the coronary sinus. Let's make this a little darker. It's right here, there. So this is opening to there, inside the right atrium. Okay. As far as the coronary vessels themselves, the right coronary artery here has two, really the marginal branch is the branch that goes down the right ventricle. And then it's going to then go around the back and go down the right marginal branch of the right coronary artery. It's in the posterior interventricular sulcus. Left coronary artery, oops, that's not quite dark enough, is going to have the circumflex branch that circumvents around to the back of the heart, and it's also going to have the anterior interventricular branch that goes down to service the left ventricle. If you go around the back, the circumflex branch of the left ventricle then comes down to the back or posterior side of the left ventricle. So those are the main branches of the coronary arteries. Again, the pulmonary trunk's been removed, so you can see where the right and left coronary artery originates. Coronary veins, again, you have the small, the middle, and the great, and they all merge to the coronary sinus, which is here, which opens up and brings that blood back to the right atrium here at the opening of the coronary sinus. Now, the anatomy is going to reflect the differences. So you have one heart contracting, right? And it's contracting and pushing in and up. And the right side is only going to the lungs, right? It's going to the pulmonary. And so it doesn't have to go that far. So it's going to be a lower pressure system. And so the right ventricle wall is thin because it doesn't need to pump far. On the other hand, the left ventricular wall is really thick. And so myocardium is thick on the left due to more muscle to pump. It needs more muscle to pump, right? You got to pump that blood to all the different areas of the body and back. Again, you need to go through all of these things. We've already gone through most of them, right? So we've talked about superior vena cava, we've talked about the right pulmonary arteries, the ascending aorta, the fossa ovale, the opening of the coronary sinus here, right atrium, pectinate muscles. It's just a pattern. So it's a pattern, a muscular pattern description. So pectinate is just describing the muscular pattern in the right atrium. It looks kind of like seaweed when you look at it if you spread it out. Conus arteriosum is where it funnels here to the pulmonary valve and the pulmonary trunk. Chordae tendineae are these cords that hold those valves to the papillary muscles here. So when the heart muscle contracts, these muscles contract as well, and they pull on those cords to make sure that these valves stay shut. And so the blood, if you notice, this blood has arrows. You only want the blood to go in one direction. And so these valves have to stay shut. These AV valves need to stay shut during the myocardial contraction or the ventricles contracting. And so the papillary muscles also contract, pull on the chordae tendineae, and hold the AV valves shut. So blood cannot go back into the atrium, but in fact has to go out of ventricles via the pulmonary semilunar valve or the aortic semilunar valve from the left. Okay, moving on, moderator band. Moderator band is a band of muscle that goes across the right ventricle wall, and it's only found in the right side only. And it's to help kind of moderate less pressure pumping that blood out of the right ventricle versus the massively higher pressure out of the left ventricle. The left ventricle doesn't have a moderator band. Going up, trabecular carne is a pattern of muscle. Okay, so trabecular carne is also a muscular pattern. So it's a description of muscular pattern. And so it looks like trabeculae of the spongy bone. It's just got holes in between and it's got these little muscular like struts and plates. The interventricular septum here is the septum, this thing that separates the ventricle, right? Enter between ventricles, and it's a septum. You have an intraatrial septum, but you don't really see it. It's kind of behind the pulmonary trunk. And then pulmonary veins, pulmonary arteries, pulmonary semilunar valve, pulmonary trunk, and ligamentum arteriosum. And of course, you have the aortic arch with brachiocephalic trunk, left common carotid, left subclavian. So that goes through heart anatomy. Do need to know all those parts. This kind of goes through the intraatrial septum and interventricular septum. You can read through these slides yourself. Again, the right atrium is getting oxygen poor venous blood via the superior vena cava and inferior vena cava, and returning it back to the right atrium. Then this is the right AV valve, and then the right ventricle. up the pulmonary trunk, right? Trunk and arteries. Pulmonary arteries. And then these are pulmonary veins. Right ventricle, again, blood goes through the right AV valve. And then up the pulmonary semilunar valve and the pulmonary trunk, and then pulmonary arteries. Right ventricle goes through the AV valves, the chordae tendineae that are held by those papillary muscles, and goes through the papillary muscles. Chordae tendineae and papillary muscles, again, help prevent blood going back up into the atriums when the ventricles contract. Right ventricle is talking about the muscular pattern, which is described as trabecular carne. And again, the right side has the moderator band that is unique to the right ventricle only, helps overexpansion of that thin-walled right ventricle while the left ventricle is contracting. Okay, so good to read through all these points so you understand. Also good to go through left atrium, receiving oxygen-rich blood from the right and left pulmonary veins. Again, there are pectinate muscles in the left atrium, and there's a left AV valve, bicuspid valve, also called the mitral valve, that is here. And there are, in fact, chordae tendineae connecting the two flaps to two papillary muscles. No moderator band, does not have a moderator band. Prominent trabecular carne because you have prominent muscles. And then it pumps up the aortic semilunar valve, which is up here. It's behind the pulmonary trunk, so you can't quite see it. And then sends it up. Again, this is brachiocephalic. This is left common carotid and left subclavian arteries. All right, so structural differences, anatomical differences, right ventricle wall is thinner, weaker contractions, has a moderator band. Left side, thicker myocardium, much more powerful contraction, and it's 6 to 7 times more powerful. No moderator band, there's nothing moderating it, it's pumping. But again, equal volumes of blood are being pumped from the right and left ventricle at the same time. So that's important to understand. Heart valves, if you're looking down from the top, these are the semilunars, right? Lunar valves, and these are the AV valves. I think the semilunar valves kind of look like guppy or fish mouths. All of these valves are opening and closing based on pressure differences between the atrium and the ventricle, between the ventricle and the aorta. And when we talk about physiology, when we get into this in physiology, we'll go through how those pressure changes opens and closes these valves. But for right now, you need to understand that these valves open and close based on pressure changes, and that the closing of these valves are what gives you your heart sound. So you kind of hear your heart and it goes bum, 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 bum. So they always say the first one is lub and the second one's dub. So you hear lub, dub, lub, dub, lub, dub. Well, you're hearing these sounds. The first sound is going to be the AV valves closing, right? So first heart sound is due to AV valves closing at the beginning of heart contraction. So systole is heart contracting. Diastole is heart relaxing or not contracting. So that's diastole. So at the beginning of the contraction, the AV valves close. That is the first heart sound. Then at the beginning of the heart starting to relax and refill with blood, you hear the semilunar valves close. And that is the second heart sound. And that is the semilunar valves closing. And so you know that your heart has filled with blood. And then this first sound is after heart fills with blood, it contracts. When it starts to contract, you hear the AV valves closing. When it finishes contracting and starts to refill with blood, you hear the semilunar valves closing. And so you know that you've had one heartbeat. When you hear the AV valves close, then the semilunar valves close, and we call that one heartbeat. It's one round of filling the heart with blood, contracting, pushing that blood out, and then starting to refill again. So that is kind of what these slides are showing you, right? They're showing you that here, the heart is filling with blood, and it fills with blood, and here's where the AV valves close. And when the AV valves close, this is where you start having contraction. And then it contracts and pushes blood out of the ventricles. After that happens, the semilunar valves close. Which are the pulmonary and aortic valves. And they close, and then you go back to here where the heart starts to refill with blood. So this would be the second heart sound. And that would be considered one heartbeat, or one cardiac cycle is what it's called. It's a cycle of filling up with blood, heart muscle then contracts, pushes blood out, and then the semilunar valves close so the heart can refill up with blood. Physicians, when they put a stethoscope up to your sternum and ribs, they are actually checking individual heart valve sounds. And so when they put it over on the right ribs 2, 3, they're checking your pulmonary semilunar valves. And so they can hear your pulmonary semilunar valves very, very good from there. When they go to, the left side, when they go to the right side, they can hear your aortic semilunar valves really well. When they want to hear the AV valves, they go lower here, kind of by towards the xiphoid process for the right AV valve, and then over towards the left for the left AV valve. And what they're doing is they're listening. So they want to hear the valve close, and then they want to hear silence. And then they want to hear the other valves close, and they want to hear silence. So they're listening just to the aortic valve and hear it close, and then they want to hear nothing. Then they listen to the pulmonary semilunar valve and they want to hear nothing. And the right AV valve and the left AV valve, they want to hear nothing. This way they can check individual valves to make sure that they are closing and they're staying closed. If they hear the valve shut and they hear like a whistle sound, or what we call a murmur, that is because, what happens is if the valve shuts, you shouldn't hear anything because it should be all going out the semilunar valve. But if the AV valve shuts, closes, and you hear a sound, then blood is squeezing back through AV valve cusps. It makes a whistling sound. So if the AV valve shuts, but you hear a whistle, it's because some blood is squeezing through those cusps that are supposed to be closed, and it makes a whistle sound. It's kind of like when you close your lips and you kind of force air through it, it makes a whistle. So that's what a heart murmur is that you hear the valve shut, but then you hear kind of a whistle or a murmur. That's really blood kind of going back through the wrong valve. And so you can have aortic stenosis where the aortic valve doesn't close all the way, and so you hear blood going back into the left ventricle, or you can have a murmur in the left AV valve where blood is going up into the left atrium after that valve closes. And so that's why the physicians or PAs or nurses are trained to put their stethoscopes in a specific place. They're listening to each one of those valves independently. EKGs or ECGs, K was for the German spelling of cardiac, and we spell cardiac with a C, so it's ECG, is just looking at the electrical current. So the electrical current, your cells should depolarize here at the SA node, and then that wave of electrical current goes down to the AV node, and then the wave goes down through the interventricular septum and then up the left and right myocardial walls. And so these are just following the waves of electrical current. Now, the direction of the wave has nothing to do with whether the electrical current is going up or down. It's just the way that it picks up the electrical current. And so the P wave is when your atrium are depolarizing, which is contracting, right? So after depolarization, the atria is going to contract. And then this QRS here, this is when the ventricles are depolarizing, which then leads to contraction. And so that's when the heart is actually pumping blood, right? And then this T wave is when the ventricles repolarization, and that's just a fancy word for resting and filling. So the ventricles. Now, we don't have a wave for the atria repolarizing or resting because it's built in here. So the atrial repolarization or resting is kind of in the QRS complex. So that's called the QRS. So it's just following to make sure that your atria are depolarizing, that the electrical current is actually flowing from the SA node. And by the way, your regular heartbeat that is set by your SA node or sinoatrial node is called your sinus rhythm. And so your sinus rhythm is set by these pacemaker cells of the SA node or sinoatrial node. AV node here, and then there's a little delay for the atria to contract and squeeze a little bit more blood down into the ventricles. So then the ventricle pressure is high enough to close these AV flaps. Then the what we call the atrioventricular bundle splits into right and left bundle branches. And then these Purkinje fibers are little fibers that innervate the wall, including the papillary muscles. This is to make sure all of the myocardium has the electrical current flowing through it. So this is the electrical system in the heart. I do need you to know the sinoatrial node. This sets your sinus rhythm. When someone needs a pacemaker put in, their SA node or sinoatrial node is, these nodal cells are not depolarizing at a rate that they should, and so they have to put in a little electrical box that will depolarize those cells because they're not doing their job. So if your SA node is not working, they will replace it with a artificial pacemaker. Then it flows to the AV node, atrioventricular node, and then the atrioventricular bundle, and in the Purkinje fibers. So these nodal cells establish the rate of contraction. The AV node can set the rate, but it's going to be much slower, and so you're not going to have enough beats per minute to meet that 5 liter per minute cardiac output, and so you're not getting enough blood flow. So having the rate of your heart set by the AV node is problematic, and that's why people have to get pacemakers put in. Problematic because they're not getting enough oxygen. If you don't have enough oxygen, your cells don't work, right? Including your brain, your nervous tissue. So normal resting heart rate between 70 and 80 beats per minute, or cardiac cycles per minute. The SA node sets this rate. Of course, your autonomic nervous system can increase or decrease your heart rate if you need to increase your cardiac output, right? Or decrease your cardiac output. So you're exercising, right? So exercise increases, so exercise increases your sympathetic nervous system, which then increases heart rate greater than your SA node rate, nodal rate. So sympathetic nervous system, parasympathetic nervous system are going to innervate and can increase the force of contraction in addition to increase the rate at which the SA node depolarizes or contracts. So this kind of goes through the different stages. Depolarization leads to contraction. Repolarization leads to rest. And so these EKGs, again, are looking at, is your heart muscle conducting system working properly, and is it flowing through all of the cardiac muscle cells? If you have had heart damage and those cardiac muscle cells have died, they don't conduct electricity. And so a lot of times if you've had a myocardial infarction in this kind of inferior ventricular area, this segment right here, it starts looking kind of like where you have, whoops, I shouldn't press on here. So let's do, what happens is it's like this, and you have the P wave, and then you have the QRS. And instead of it going like this, it just kind of slopes back to a T like that. And so instead of it being sharp like that, it's kind of sloping gradually. So this would be like someone that had an MI in left ventricle wall. You look at ST segments, and they should be a certain amount of time and so forth. And when you're doing a treadmill test to assess heart muscle function. So again, systole is contraction or ejection of blood. Diastole is relaxation, or when you're passively filling. And I would like you guys to read through this cardiac cycle, right? This is a full cardiac cycle. Now, if you may notice, ventricular diastole or rest is a very long period of time at rest. It's half of the amount of the cardiac cycle. So remember, going from 5 liters per minute to 30 liters per minute, this is what gets shorter, right? So you have a shorter ventricular diastole with 30 liters per minute. There's less time in between contractions, right? The downside is your heart has less time to fill back up with blood. And so when you're going 30 liters per minute, you have to be pretty fit. Your heart has to be a really good pump, because it's got to fill very quickly and then contract very quickly. So as a muscle, it has to be in shape. I want to finish off with cardiac output, right, is in liters per minute. And so what this actually is, I'm going to say cardiac output is equal to heart rate, right, which is cardiac cycles, number of cardiac cycles, right? And we say beats per minute times stroke volume, and that's usually in liters. I should say liters, liter per contraction or beat. Okay, so it's how much blood is being pumped, right? So that's stroke volume, how much blood. And so if you look at it, if you have a really high stroke volume because your heart is really strong, it's a super strong muscle, you work out all the time, you do cardiac or aerobic type exercise, your heart's going to be strong. It's like any muscle. The more stress you apply to it, the stronger it gets. So if you go running or swimming or biking, hiking, whatever, you do it, you're making your heart have to pump at a higher cardiac output, it's going to get stronger. It's like telling it to lift more weights or having it lift more weights. If you can pump a large volume per contraction, and you only have to meet 5 liters per minute, then your heart rate doesn't have to be as much, right? Because if you can pump a high volume per contraction, you don't have to contract too many times. You can lower the contraction rate. And that's why people that have strong hearts have lower heart rates. So that's cardiac output. Again, the autonomic nervous system, this would be sympathetic, and this would be parasympathetic. And we talk about this more in physiology. Sympathetic, by the way, innervates the muscular wall as well as the SA node, whereas parasympathetic just innervates the SA node. And that concludes chapter 20.